abdominal pregnancy in third trimester. This case was that of a 32-year-old gravidatrice para 2, one alive, whose last childbirth was 12 years prior to presentation. She was unsure of her date, was said to be 8 months pregnant. She presented with a history of absent fetal movements following an episode of severe abdominal pain 3 days prior to presentation. Ultrasound confirmed a non-viable abdominal pregnancy at 29 weeks 5 days. Her Pax-A volume at presentation was 18%. She was transfused 4 units prior to laparatomy. Note the empty and bulky uterus with anterior-posterior asymmetry, probably due to uterine contractions at 29 weeks 5 days of gestation. The transverse section of the uterus showing close proximity of the degenerating placenta to the uterine fundus. Here, not what looks like invasion of the placenta into the ovarian artery, as also supported by this high definition Doppler. Again, note the neovascularization between the placenta and the fundus of the uterus. The surgeon was invited to note these findings so as to reduce hemorrhagic mobility at laparatomy. Note that there is no definable structure here, which is a feature of maceration, the empty thorax and empty abdomen sign. Not free fluid in the pouch of Douglas with blood clot, free fluid with blood clot. Despite the fact that the placenta is undergoing degenerative changes, not the vascular activity. Again, not the vascular connection between the ovarian artery and the placenta. No wonder the surgeon did the right salpingectomy so as to control bleeding from these anastomosis. Here, the membranes were left in situ because of contact bleeding, but the placenta was delivered poorly. Intraoperatively, the findings were that of hemperitoneal occluded blood of about 750 ml. So this explains the sudden onset of severe lower abdominal pain, probably because of placenta separation, and also explains the Pax-A volume of 18% at presentation. This explains also why there was no fluid in the Mauritius pouch, because most of the blood was clotted. The fetus was a macerated male fetus found floating in the peritoneal cavity. The membranes were adhered to the uterus, bowels, and amentum. The placenta was adherent to the right fallopian tube and ovary, and in close proximity, the corner of the uterus on same side with multiple neovascularization, but mainly the ovarian artery. The left fallopian tube and ovary were apparently normal, but very inadhesions. The membranes easily bled on contact. The uterus was about 14 weeks size. She had a wide salpingectomy and partial ovarectomy because of adhesions. Estimated blood loss was 400 ml. The estimated blood loss was insignificant, probably because ultrasound was used as a GPS to guide the surgeon to reduce hemorrhagic mobility. Here we have the video of this case: the bladder, the vagina, cervix, the bulky uterus, free fluids in the pouch of Douglas. So again, cervix, uterus, not the anteroposterior asymmetry, prominent aqueous vessels, not the relationship between the fundus of the uterus and the placenta, and these adhesions between the placenta and the fundus of the uterus. The bowel here, blood clots here, the empty thorax and empty abdomen sign. No fluid in the Mauritius pouch, probably because the blood is already clotted, as you can see. Clotted blood here. Again, not the clotted blood here, not the placenta here. And the bowel and the iliac vessel. Too close for comfort. So this separation probably explains the sudden onset of abdominal pain and the fetal demise. Not the bowel here, adhere to the placenta here, and not the close proximity here of the placenta to the iliac vessel, not the neovascularization between the placenta and the fundus of the uterus. Deformed fetal skull. Fetus was in blood clots. Again, one cannot differ. So the structure here, so the empty thorax and empty abdomen sign, a feature of maceration, degenerating placenta, bowel, again the deformed skull, the neovascularization, the highly vascular placental bed. So our learning point is that use of ultrasound as GPS will guide the surgeon in reducing adverse outcomes.